Good evening, madam. Dr. Rakshana, you are there?
Yes, sir.
Can you just try sharing your screen once? Sir?
Okay, sir.
Good evening, madam. Sangeeta, madam.
Can you hear me?
கொஞ்சம் ஆடியோ கம்மியா வருது மேடம்.
Volume. Okay. Yes.
Good evening, madam.
Hello, good evening, Susana.
Good evening, madam.
Sorry, கொஞ்சம் லேட் ஆயிடுச்சு. அந்த கேர்ள் லாகின் பண்ணிட்டாங்களா?
லாகின் பண்ணிட்டாங்க மேடம்.
ஓகே. அவங்க பிபிடி உங்கள்ட்ட இருக்கா?
டாக்டர் லக்ஷனா நீங்க ஷேர் பண்ணுங்கப்பா.
Yes, sir.
Can you
Can
share?
do it now, Rachana?
Yes, ma'am. I'll share the
You just try once before we start. Try
Okay.
sharing your screen.
ஒரு தடவை ட்ரை பண்ணு.
Good evening, ma'am.
Sangeeta வந்துட்டியா? Okay. Good evening, Sangeeta. How do we go about? Let us start presenting.
Yes, madam.
Yes.
முதல்ல அதையே ஒரு 50 இப்போ இல்ல ஒரு 5 சார் வந்துட்டாரு இப்பதான். Sir, good evening, sir. SB sir
Good evening, Dr. Lakshmi and Sir Sangeeta.
Sir, good evening, sir.
Good evening, Bala, and good evening, madam. Good evening,
Sir,
Professor
Srinivasan, sir.
So nice to hear your
Thank
voice.
you, sir.
Yeah.
So nice of you to have
Thank
joined with us, sir. Thank you very much, sir.
Thank you. It's only the learning process for me.
Sir,
evening,
sir,
Professor.
நீங்க அப்படிலாம் சொல்லாதீங்க, sir.
என்ன அப்படியே every day is a learning day.
Definitely, sir.
I
Sir,
think you
நம்ம
master
எப்படி
teachers.
எஸ்பி சார் நம்ம எப்படி ப்ரொசீட் பண்ணுவோம் சார்? அந்த பொண்ணு பிரசன்ட் பண்ணும்போது क्वेश्चंस நாங்க கேட்டுட்டு இருக்கோம்.
மேடம்
அப்புறம் நீங்க கன்சாலிடேட் பண்ணிருங்க.
என்ன வேணாலும் பண்ணலாம் மேடம். நீங்களும் சங்கீதாவும் என்ன வேணாலும் பண்ணலாம். ராகிங் கூட பண்ணலாம்.
நோ 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 சார், அதெல்லாம் பண்றதா இல்ல சார்.
சும்மா தமாஷ் சார்.
கரெக்ட்.
Let not the student get worried. No.
worried அவ்வளவுதான் சார். 50க்கு மேல போனோனே ஆரம்பிச்சிருவோம் சார்.
Doctor,
அதுக்கப்புறம் பசங்க
Bala is in hectic mood now. Last year I was with Bala in Bombay platform. So I learned so much from him. Oh God.
என்ன டாபிக் சார்?
Every Friday in Nalin.
Good evening, Susana. Sorry, கொஞ்சம் லேட் ஆயிடுச்சு.
மேடம் ஒரு எக்கோ அது எங்க இருந்தோ.
அந்த கேர்ள் லாகின் பண்ணிட்டாங்களா?
லாகின் பண்ணிட்டாங்க மேடம்.
ஓகே. அவங்க பிபிடி உங்கள்ட்ட இருக்கா?
டாக்டர் லக்ஷனா நீங்க ஷேர் பண்ணுங்க.
Yes, sir.
Can do it now, Rachana? Yes.
Yes, ma'am. I'll share the
You just try once before we start. Try
ஒரு தடவை ட்ரை பண்ணு.
Ma'am, my screen is audible.
Yeah, we are able to see your slides, Rachana.
Yes, ma'am.
உன் slides தெரியுது.
Okay, ma'am.
And we are able to hear you also.
Okay, ma'am.
Okay, good. இன்னும் கொஞ்சம் சத்தமா இருந்துக்கோ. No need to be worried. We'll be asking the questions. தெரியலன்னா நாங்களே ஆன்சர் சொல்லிட்டே இருப்போம். Okay?
Okay, ma'am.
Okay, don't worry. Sangeeta is there for you. We are all just ஒரு UG presentation மாதிரி ஆரம்பிச்சிட்டு we'll just give you some facts. Okay? Nothing to worry.
Will there be other students responding before you answer, madam?
இல்ல சார்,
Only one
யாரும் இல்ல
snapchat.
சார், அவங்க ஒரு ஆள் தான், சிங்கிள் பர்சன் தான்.
Okay. So in the platform, the other students are not joining.
சாட்ஸ்ல சார் வந்து அவங்க ஏதாவது கொஸ்டின்ஸ் ஏதாவது போட்டிருந்தாங்கன்னா ப்ராபபிலி
Okay, chat box.
Sangeeta
Okay.
will be answering the chats also.
Thank you.
Good evening, everybody. On behalf of IAPCCB, I welcome you all for this meeting. This meeting is a PG teaching program which IAPCCB Presidential Action Program under Dr. Somasundram sir's guidance. So we are very happy to have Dr. Lakshmi Velmurugan Madam, Director of ICH Egmore, Madras Medical College, Professor and Head. Madam is here to give her valuable suggestions and comments and to take this program to next level. We also have Dr. Sangeeta. Dr. Sangeeta is formerly Assistant Professor in Sri Ramchandra Medical College. She is a Pediatric Nephrologist and she is now currently working as Senior Consultant in Kaveri Hospital, Pallavaram. Welcome you, Madam. I also welcome our convener, sir, Dr. SBS sir, and Dr. Srinivasan sir, to just make this program reach to a new height. Last month we had a wonderful session on neurology, chaired by Dr. SBS sir. This month we have planned nephrology to be chaired by Dr. Lakshmi Madam and co-chaired by Dr. Sangeeta Madam. Dr. SBS sir, a few words from you, sir.
Thank you, Dr. Prasanna. At the outset, I'm extremely happy to be part of this wonderful program planned by the IAP Chennai City President, Dr. Somasundram. Dr. Prasanna is the right person to take us through all the sessions. And I'm more than happy today because Professor Srinivasan has joined this session. Welcome you, sir.
Thank you, sir.
Today, we are going to have two experts. One, a veteran who has, a lot of wisdom, lot of experience, lot of practical knowledge, and one who's very, very capable and a well-known teacher, none other than Dr. Lakshmi Velmurugan.
Thank you, sir.
She is very well known for her, forthright views. She is very clear about whatever she says whether in meetings, whether it is a CME or a PG session. She is absolutely crystal clear, like her husband, Professor Velmurugan. And she is going to be helped by she's going to be assisted by somebody who has youthful wisdom, Dr. Sangeeta, a pediatric nephrologist. I welcome both of you and take the session to greater heights.
Thank you, sir.
Over
Thanks
to
a lot for that.
Dr. Lakshmi and Dr. Sangeeta.
Sir, Dr. Somasundram sir.
Yeah, so good evening. First of all, my thanks to Professor Lakshmi Madam. So we wanted to start with you, Madam, after our convener. We are very happy to have our director and Professor of Pediatrics, Madras Medical College, to be the faculty for the session 2 after Dr. SPS sir, who did it session 1. So we are starting from our alma mater, that is ICH. To assist you, we have Dr. Sangeeta, who is a well-known nephrologist of the town, now currently with the Kaveri Hospital. And my sincere and grateful thanks to Dr. SPS sir and keeping him troubling a lot. And he is again back to the session 2 also to guide the postgraduates, sir. Thank you for your presence today and sparing your time. And we have our teacher of teachers, Professor Srinivasan sir, also with us. It is a blessing to us, sir, to be with the to be on our forum, that is our Zoom platform. Already 81 people are there in the Zoom, and few people are already there in the YouTube waiting for your knowledge. And but not the least, my sincere thanks to Prasanna. he is. I have given this job, and I now contented person that I have chosen the right person to do this job in liaison with the SPSR to choose the specialty, to choose the faculty, the guru and the Sishyan and all. Thank you, Prasanna. You are doing a great job in this thing, and this has reached various levels. So without wasting much time, so to hand over to Prasanna to carry the formalities. Thank you very much.
Thank you, sir. Doctor, can you start your presentation, Doctor?
Yes, sir. Good evening, ma'am. Good evening, sir. I'm starting my case presentation. So this is about.
Please introduce yourself. Please introduce
yes, sir.
yourself.
Sir, I'm Dr. Rachna, doing my post-graduation in Sri Ramachandra Medical College, sir. I'm currently in my final year, sir.
Okay, Rachana. Okay.
Yes, ma'am.
I would like to tell one more thing. Sangeeta is our ICH alumni. I'm very, really proud of it that she is chairing this session with me. Okay, Sangeeta. Thank you, Somsundaram and Prasanna, for this opportunity. We'll start the session.
Our Dr. Singaravelu sir is also there in the chat, sir. Thank you.
Thank you, sir.
Thank you, President.
Okay, sir.
SBS, sir.
Thank you, sir.
Good evening,
Thank you,
Singarwell, sir.
Good evening. Good
Yes,
evening.
sir. Okay. Thank you, sir. Thank you.
Thank you, sir. Thank you, sir.
Dr. Rachna.
Yeah, yes.
Yes, sir.
Rachana?
Yes, ma'am. Good evening. Good evening, sir. I am starting my case presentation. So this is a 7-year-old girl child hailing from Chennai. She was brought to OPD by her mother, whose reliability is good, with complaints of swelling around the eyes for 2 days, swelling of both the feet for 2 days, decreased urine output for 1 day, and blood in urine 1 episode. History of present illness, history of periorbital swelling for 2 days that was insidious in onset, more in the morning, immediately after waking up, and it decreased as the day progressed. History of pedal edema for 2 days, insidious in onset, and progressed to involve both the hands, followed by abdominal distension for 1 day. History of decreased urine output for 1 day. She normally voided 5 to 6 times per day. Last 1 day, she voided only twice. There was one history of one episode of hematuria that was painless.
That's not, wait. And now you have the swelling started in the periorbital region, then progressed to abdominal distension and pedal edema.
Yes,
No,
ma'am.
pedal edema and abdominal distension. So what do you think is the cause of edema in this child?
This is probably a renal cause, ma'am, because it started in the periorbital region involving the lower limbs and followed by abdominal distension.
Suppose, what are the other causes of edema usually? Renal cause, one of the causes. Other causes?
Other causes can be because of hepatic failure or congestive cardiac failure, ma'am. In
Where
hepatic,
does edema start in hepatic failure or decompensated liver disease?
it starts as abdominal distension, then involves the lower.
Vasculitis, yes. Okay. In a case of cardiac case, why do you have pedal edema starting first? Or a sacral edema, dependent edema?
Dependent edema, and then it involves the abdomen, ascites, and then phase it happens. And because of the impair in the venous retin, there is stasis of.
Okay. So this child, since it started in the periorbital region, and its progress, you think it is probably renal edema. Now you have told me there is a child voided only twice.
Yes.
What do you call it as now? You want to call it as oliguria, anuria, or do you have any terminology for these two? Or any specification for oliguria?
Oliguria is if the urine output is less than 0.5 ml per kg for 6 hours.
0.5 ml per kg?
Per hour for 6 hours.
Oh, very good. Excellent. 0.5 ml per kg per hour for 6 hours. Okay. Yes, then?
Anuria is less than 0.3 ml per kg per hour or the child didn't void urine over 12 hours, ma'am.
Okay, so far so good. Very good. Very good, in fact, Rachana. You have said history of hematuria, 1 episode painless. You want to elaborate more on that? Because that becomes a totally different entity.
Yes, ma'am.
Yes.
So this hematuria.
You just described that hematuria which occurred in this child. For example, it was a hematuria. Whether it was just one episode, blood streaked urine, or was it mixed with clots? Painless, you have said. Other things also you try to call. You just give more information on that.
Okay, ma'am. There was history of 1 episode of hematuria that was painless. It was not associated with clots, ma'am. It was like streaks of blood and urine she had, ma'am.
It was not associated with clot. One episode, after that, she never had hematuria.
Yes, ma'am, no, ma'am. She didn't have any episode of hematuria.
What is
Common
the
causes
exact
of
color?
hematuria. Okay, yes. I never had hematuria, just one episode. Doubtful or definite?
Probably doubtful, ma'am, because she had only one episode that was painless, ma'am.
Wanted to confirm
Yes,
whether
ma'am.
it was truly hematuria. Okay, at this point, we'll just leave it as, and you have said painless hematuria. Can you just tell me some common causes of hematuria? And painless hematuria, immediately, what do we usually think of?
Ma'am, glomerular, if there is glomerular etiology, the hematuria can be painless, ma'am. If it is
Okay.
involved the like non-glomerular lower UTI or cystitis, there can be hematuria can be there can be painful, ma'am.
Glomerular is painless, you say. Okay, yes, that. And another, what did you say? Painful hematuria is due to urinary tract infection or due to stones. Okay. So this child, you want to confirm the hematuria later. Okay, we'll leave it at this point. But again, now renal edema, you have thought of what are the two conditions you want to now rule out? A child who has got renal edema and child has got decreased urine output. That is definite.
Yes, ma'am.
And with hematuria, what are you thinking in terms of age of the child is 7 years?
7 years. It
What are
can.
the two conditions? Yes.
So it can be like acute glomerular nephritis, wherein there can be hematuria, decreased urine output, ma'am.
Okay. It can be acute glomerulonephritis because of hematuria and oliguria. You want to think in terms of glomerulonephritis. Okay. In these 4 points itself, what is against your probably against your glomerulonephritis? You have just showed 4 points here. What is against glomerulonephritis?
Significant edema, ma'am.
Anasarca, massive pedal edema, abdominal distension, and your abdominal distension and edema of the hands and feet. Okay, this is a little not usually we don't get anasarca in cases of in anasarca is unlikely in acute glomerulonephritis. You can have periodal edema, but it will not be mass. Okay, but we are just open now. Go ahead. We'll see what's happening.
Okay, ma'am.
Yes, go ahead. Sangeeta, you want to ask us something, Sangeeta?
When you're saying painless cola urine, Rachna,
Yes, ma'am.
what is the color of the urine exactly?
Yeah. Frank or cola color?
So
Cola
as
urine is more in favor of glomerular etiology.
yes, ma'am.
Okay, yeah.
Yes.
So with the history alone, can you differentiate whether it is glomerular and non-glomerular? You will go by edema will be there in glomerular hematuria, and they will have painless cola urine.
Okay, ma'am.
Right? If it is IgA nephropathy, you may get sympharyngitic hematuria. In case of PAGN, they'll be associated with other symptoms like headache, vomiting, or hypertensive symptoms. And you can also get sore throat and impetiginous lesions.
Okay, ma'am.
Right?
Yes, ma'am.
For non-glomerular hematuria, usually urinary tract infection, renal stone disease, they will present with the urgency, frequency, loin tenderness, and clinically there won't be any edema or hypertension. Then finally, you have to differentiate with the investigations. Proteinuria will be common in glomerular hematuria, and RBC cast, dysmorphic RBCs will be evident.
Okay, ma'am.
Renal function may also be altered in case of PAGN, and complement levels also will be low.
We'll go
Whereas
for the
your-
investigations a little later, Sangeeta. Can you,
Yes,
you
ma'am.
proceed with the history? Yes.
Okay, ma'am.
Yes. Go ahead. Rachana, next.
Yes, ma'am.
Hello?
Rachana,
Yes.
is the slide moving?
Slide is moving, ma'am.
We are
Please
not
go to the
able to
next
see
slide.
this.
Please go to the next slide.
Go to the next slide.
Okay.
Yes. Next slide.
Uh,
Yes.
Make it full screen. Make it full screen. Slideshow.
Slideshow. Okay, sir.
Yes. Rachana, it's obvious. Yes, Rachana, proceed.
Yeah, no history of frothy urine. No history
Okay,
of
frothy urine is very characteristic of what?
it is
Have you
seen
seen a frothy urine?
yes, ma'am. It is seen in
Yes, it's very characteristic. It indicates what?
It's because of the proteinuria, they'll have this frothy urine.
Frothy urine. Very good. Okay, proceed. Then
No history of coughs, coughs, sore throat, or skin lesions.
in lesions, you wanted to ask all this to rule out?
To rule out, so because of cough, sore throat, and skin lesions, it can progress to nephritic, ma'am. So, PIGN.
Okay. Skin lesions or sore throat, which you were very particular at.
Sore
Both
throat.
can occur, but still. Sore throat. Okay.
Sore
For
throat.
renal,
Ma'am. Skin
molecular
lesions.
mimicry is more for
Skin lesions.
skin lesions. For sore throat is more for rheumatic heart disease. What are the strains? Skin lesions. What skin lesions you are looking at?
Impetigo, ma'am.
Post-impetigonous scars you are looking at. Okay, how do you treat impetigo?
In case if it is local, we can try mupirocin ointment.
Very good, excellent. Yes.
If it is involving dangerous area of the face, or if it is associated with some pus, we can give oral antibiotics, ma'am.
Like?
Preferably amoxiclav or first generation.
I was just waiting for you to tell amoxiclav. You want amoxiclav or amoxicillin?
Amoxicillin, ma'am.
No. Why are you going back? You want amoxicillin or skin and soft tissue infections? You want amoxicillin or amoxiclav?
Amoxiclav.
Okay. How much? How? For how many days?
We can give 40 mg per kg per day, ma'am. 40 to 60 mg per kg per day.
Good, very good. So you know the management of skin lesions. So what are the strains? Probably 1 or 2 strains you can mention.
Ma'am, M4, M1.
Okay, doesn't matter. Okay, go ahead. Next.
No history of dyspnea, chest pain, palpitation.
For everything you tell us, why did you ask for dyspnea, chest pain, palpitation? Why did you ask?
To rule out the cardiac causes of edema.
Okay. Can you get dyspnea, palpitations in a case of acute glomerulonephritis? That is the case which you're thinking in terms of. Can you get that? Yes. What is the cause of dyspnea, palpitations in a child with AGN? Probably child has gone in for volume overload, or due to hypertension, child could have had a cardiomegaly, and the child can have for congestive cardiac failure too. Either due to volume overload or due to the associated hypertension, okay, in AGN. That's why we ask. Proceed.
No history of yellowish discoloration of eyes or bleeding manifestations, like hematemesis or melena. No history of. This is for the hepatic causes, to rule out the hepatic.
Okay, good. Yes, next. Loss of appetite, loss of weight, just like that you asked. Okay. History of insect bite. What insect bite?
Bee stings can sometimes cause nephrotic
syndrome, rarely. Okay. Drug intakes. What drug for what condition?
Drugs like penicillamine, ma'am. Anti-epileptics, NSAIDs.
NSAID, very good. You didn't tell gold. Thank you very much. D-penicillamine and NSAIDs you wanted to ask. Why? What do they cause? They usually cause?
Proteinuria, they'll cause, ma'am. Okay,
very good. Okay, next question. You wanted to rule out UTI, then fever. Then why did you ask for headache, seizures, altered sensorium, blurring of vision?
Nephrotic complications of nephrotic, ma'am. They can have thrombus, cortical vein, like thrombosis, seizures, or hypertensive encephalopathy.
Or associated hypertension in a case of EEG. Okay, good. Yes.
No history of facial weakness or a weakness of limbs, ma'am. Again, thrombosis manifestation.
Okay.
No history of abdominal pain, nausea, or vomiting, ma'am. To rule out SBP.
To rule out?
SBP, ma'am.
Spontaneous bacterial peritonitis. Okay, good, ma. So far, very good. You have answered everything. Yes, go ahead, Rachana.
Past medical history. So this child had first episode in February 2024. She had a similar complaints of periorbital puffiness, pain edema. She was admitted, evaluated, discharged on medications. She had regular follow-up on OPD basis. Second admission was in July 2024 for the same complaints of anasarca, discharged on medications, but then she was on irregular follow-up. Third admission on November 2024 for the same anasarca complaints, again discharged with medications, but then she was on regular follow-up, irregular follow-up. This is her fourth admission for the same complaints. So there has been 4 admissions over the past 1 year for the same complaints of periorbital edema,
Okay,
abdomen.
Rachna. Now here you tell us the child has been having relapses and remissions. So immediately what has become your diagnosis?
Nephrotic syndrome.
Syndrome. Okay. How many relapses child has had?
So this child has had 4 relapses over the past 1 year, ma'am.
What do we call it as?
Frequent relapses, ma'am.
What are the other to qualify as frequent relapses? How many relapses you should have?
There has to be more than 2 relapses in 6 months, or 3 relapses in any 6 months, and 4 relapses in a year.
Yeah. So this child qualifies for
a frequent relapse, ma'am.
Frequent relapses of nephrotic syndrome. Here, though the child had a faint episode of hematuria, since it had relapses and remissions, you are now thinking in terms of nephrotic syndrome. Okay, yes, go ahead.
Yes. Birth history, antenatal, booked and immunized. She had regular mother had regular antenatal visits. And then supplements were taken.
The child is 7 years old. Do you attach any importance to this antenatal history?
No.
Hello, please mute yourself. Somebody is speaking. Thank you.
Yes. You want to attach any importance to this antenatal history? 7 years old child. 7 years, it is the age for nephrotic syndrome or nephritis, Rachana?
Ideal age for nephrotic is 2 to 6 years of age, ma'am.
Okay. So this disease has started by 6 years. So still you think in terms of nephrotic. Okay. Yes. Now for this antenatal history, importance in that.
Suppose if mother has had oligohydramnios, there can be history of renal disease or antenatal scans showing any renal pathology.
Okay. You ask routinely, but when do you call it as congenital nephrotic syndrome?
If it presents less than 3 months of age.
3 months of child. Yes. Any child less than 1 year, we are always vigilant, but less than 3 months, definitely we think in terms of congenital nephrotic. So here there is no significant antenatal history. Proceed.
Natal history, she is a term baby, delivered 39-weeker, delivered by LSAs in view of non-progression of labor. Birth weight was 2.5 kgs, cried at birth, breastfed soon after birth. There was no NICU admissions.
Okay.
History, milestones attained at appropriate age. She is currently in 2nd standard with average scholastic performance. There has been school absenteeism because of the relapses she has had.
Yes. For the past 1 year.
Yes, ma'am.
Child is not at 2nd standard, but not going to school regularly for the past 1 year.
Yes, ma'am.
Okay. Yes.
Immunization history. She is immunized till date according to the National Immunization Schedule. She was last immunized at 5 years of age. Optional vaccines were not taken.
Are you worried or not? Now
Yes.
here you pause. What all you would like to do now? Probably thinking in terms of nephrotic syndrome with reference to your immunization schedule. What you would like to do?
She has to be immunized.
What are the vaccines for which you will give importance?
Pneumococcal, varicella, influenza, hepatitis.
Pneumococcal child has had?
She was immunized till date according to the national schedule, ma'am. So she would have got immunized with the pneumococcal.
This child is 7 years old. 7 years old. I really doubt. Did you check the card or something?
Card was not with the
7 years முன்னாடி governmentல நாங்க pneumococcal கொடுக்கல.
Yes,
that will play an important role in it is not received ரொம்ப important information இருக்கும்.
Yes,
did you ask the patient specifically just immunized up to date அப்படின்னு நம்ம you should have concentrated a little more here, Rachana. Okay. If you have asked something, you tell me.
Okay, ma'am. So I asked specifically about pneumococcal vaccine, varicella, influenza. They have not taken that, ma'am.
Okay, now they have not taken. Now you know it's a case of nephrotic syndrome probably. What will your advice be?
Now that she is more than 6 years of age, I will give her a schedule of pneumococcal polysaccharide vaccine.
Yes, PCV.
PPSV 23, ma'am, for varicella, influenza, annual flu
So
vaccine.
PCV 23 alone you want to have?
PPSV 23, ma'am, polysaccharide vaccine, 1 dose and 2 weeks, like then PCV, and then 2 months later, PPSV 23, ma'am.
Sir, you want to, it's an unimmunized child, completely unimmunized child. So the vaccine schedule will be? You want to give PCV 13 also?
Yes, so we'll give polysaccharide vaccine 23, ma'am. Then PCV 13. Then 2 months later, PPSV.
13, 2 doses, 8 weeks apart, followed by PPSV 23, 1 dose. That's the shape. That is unimmunized child. Probably that is what we should give. Okay. Then you want to give the next vaccine which you want to give is?
Annual flu vaccines, ma'am.
Annual flu. Very good. Excellent. Then?
Varicella.
Varicella, you have already told me.
Then
anything else?
Look for the hepatitis B titers.
Very good. Okay. The child might have had. It might have had. Okay. So these are the 4 vaccines which you are going to concentrate. Okay. Okay, Rachana, proceed.
A nutritional history. She predominantly consumes vegetarian diet. She consumes junk food.
Junks, JUNCS.
She
potato chips
she'll take a lot of bakery products.
Okay.
Potato chips, salt, pickles. That will be her predominant. Like she'll consume a lot of that one.
Will it affect her disease? Does it make a role? Is there a role? Is it important that she consumes a lot of pickles? She consumes a lot of processed foods, like bakery foods. Is it important for this child?
Yes, ma'am, because we have to advise them not to take added salts in that diet, ma'am.
Okay. Yes. You give me some more examples of these processed foods. One, you said bakery items you would ask her to avoid. Then? Pickles, you told me she's taking a lot. You want to avoid. Yes. Then?
This puppet type. Take a lot of fruits and
vegetables. Yes. Yes.
Take a lot of fruits and vegetables, ma'am.
This child is coming from a rural area. Usually we tell them no processed food, no processed soups. Yes. Then?
We should advise them to take egg regularly, ma'am.
Okay, that will come again. We'll come whether egg, how many eggs and all that will come later. So junks, can you expand for me? JUNCS.
Yes, ma'am.
You like to read later and tell me. Okay. Yes. Okay, I'll leave you now. Okay, JUNCS. That is the short notes for you. Okay, so you should know about it, especially when you have specifically written consumes junk food. You should also know about. Okay, Rachana, proceed.
So by 24-hour recall method, she's expected to take 1,300. There is a deficit of 542 calories. 24 grams of protein she's expected to take, and there is a deficit of 9 grams per day of proteins, ma'am.
Okay, 500 calorie deficit she's having. Okay, yes, proceed.
Family history: she's only child born to non-consanguineous marriage, and there is no history of renal disease in the family.
Okay, okay. Sir, SP sir, eda kekkalama neenga? Sir?
Yeah. No, I'll come in. Dr. Lakshmi, you're doing so well. I don't think I can add anything. You go ahead. I'm just noting down a few points which I'll tell
points. In the end. Yes, sir. Okay, sir.
Complete. I'll come in the end. Don't worry.
Okay, sir. Yeah, leave the slide. Next, okay. Next slide.
Provisional diagnosis, ma'am. A 7-year-old developmentally normal girl born to non-consanguineous marriage with no significant family history, presenting with 4th episode of periorbital swelling, pedal edema, abdominal distension with decreased urine output on irregular follow-up and poor compliance to drugs is probably of renal etiology. A case of nephrotic syndrome with frequent relapse now has presented with 1 episode of hematuria.
Okay, very good. Proceed. Clinical examination.
On examination, she was alert, oriented, afebrile. There was pallor, no icterus, cyanosis, clubbing, generalized lymphadenopathy, anasarca in the form, like she had facial periorbital puffiness, pedal edema, ascites. Vitals, pulse rate 102 per minute. There was regular rhythm, normal volume.
It's a female child?
Yes, ma'am.
It's a female child. Did you look for labial edema?
Yes, ma'am. She had labial edema, ma'am.
It was that. Please mention, because scrotal edema or labial edema usually indicates anasarca, and that's again, it's a marker that is likely to be nephrotic syndrome. It indicates anasarca is massive. Okay, proceed.
Vital's pulse rate was 1 or 2 per minute, regular rhythm, normal volume pulse. Peripheral pulses were well felt. Capillary refill time was less than 3 seconds. BP measured in the left upper limb in the sitting posture, it was 90/60. Respiratory rate was 24 and she was afebrile. Anthropometry weight was 18.5 kgs, which is falling in the 10 to 25th centile. Before admission, her weight was 15.2 kgs, which was 3rd to 10th centile. Height was 114 centimeter, 10 to 25th centile. BMI put for the weight before admission, it was 11.6. Head-to-toe examination, there was BCG scar in the left arm, lustreless hair, eyes normal, periorbital facial puffiness, oral cavity, there was crowding of teeth with dental caries, throat normal, nails normal, no dysmorphic facies, no skin lesions, no skeletal
What skeletal deformities you look for?
Ma'am, in nephrotic, there can be a vitamin D deficiency, ma'am. So associated
Producing rickets or just a vitamin D deficiency, biochemical deficiency?
rickets, it can.
See, it's only if the child has gone in for.
Or general skeletal deformities, we can see.
No, you wanted to look.
Toxicity.
Okay, steroid toxicity produces what bone problem?
Osteonecrosis.
Osteoporosis. It produces osteoporosis. Okay, that producing deformity due to fracture, you thought.
Yes, ma'am.
Okay, and what I was trying to tell you is rickets as such, unless there's a CKD, it's a little unlikely. So they can have biochemical vitamin deficiency accepted. Okay, go ahead.
No signs of liver cell failure or no Cushingoid features, ma'am.
It's very unlikely, no? This child has been had 4 relapses. So what does it indicate? A child has not developed any Cushingoid features at all.
Because she had poor drug complaint. She was on irregular follow-up.
Yeah, that's what I want to tell you. That the cause of this 4th relapse is probably this child is not having a good drug complex. Excellent. No Cushingoid features. Probably you felt it was not due to good drug complaints. Good. Proceed.
Examination of abdomen, inspection, abdomen was distended, umbilicus was in midline slit-like, all quadrants moved equally with respiration, there was no visible scars, sinuses or dilated veins, no visible peristalsis, flanks were full, external genitalia, there was labial edema. Palpation, abdomen was soft, non-tender, no organomegaly, percussion, there was shifting dullness, auscultation, bowel sounds were heard. Other system examination, CVS S1 S2 heard no murmur, RS bilateral air entry present, no added sounds, CNS GCS was
15. Specifically, what did you look for? Air entry is there, but what were you expecting?
Equal, if it is equal.
That's okay. It's equal, you have told me, but நீங்க specifically எது concentrate பண்ணீங்க? Air entry இருந்திருக்குமா? நீங்க எதுக்காக பார்த்தீங்க air entry?
Because
routine பாத்தீங்களா?
Because there is anasarca can involve serious
you were expecting a right-sided pleural effusion and a decreased air entry you were looking for. It can be right-sided pleural effusion or for bilateral pleural effusion. It can be anything. Okay.
CNS GCS was 15/15. She was alert oriented, no focal neurological deficits. Diagnosis: a 7-year-old girl presenting with 4th episode of periorbital puffiness, abdominal distension, decreased urine output, who is on irregular follow-up and poor complaints to drugs. With examination showing pallor, anasarca, shifting dullness per abdomen or percussion, is probably a case of nephrotic syndrome with frequent
relapses. What would you like to do now?
So we'll admit the child, ma'am, and then start basic. So since she's a known case of nephrotic syndrome, we'll do urine routine. Urine
routine, what do you mean?
Urine routine, we'll look for urine albumin. Because she had episode of hematuria.
You want to look for urine albumin.
Yes.
Now, you give any specific instructions to the patient, whether any random sample you want to collect, or you're very particular about early morning specimen?
Early morning sample.
Or whatever be the specimen, doesn't matter.
Early morning sample, early morning sample, clean catch midstream sample should be taken.
Why do you want a clean catch midstream? For urine albumin? Whether it is needed, that's why I'm specifically asking. For example, and it is not mandatory to have early morning. It is preferable to have early morning, but no, if child, it's not possible also, no problem. In the same way, your mid-catch clean, your midstream clean catch urine is only for UTA.
Okay.
For a ALB, you can take at any point of time. It is not mandatory that you should have only a mid. For a urinary tract infection, you want a clean catch midstream urine. Okay. Okay. Any time is okay, but preferably early morning. Okay. That you have taken. You wanted to do an urine albumin. What method you want to do?
Ma'am, there is we can do urine dipstick test.
Okay.
Uh,
Dipstick you can do. What else you can do?
we also have heat coagulation.
Heat coagulation. So, okay. If both are available, what do you want to do?
We'll do heat coagulation method.
No, both are available, I have told you. And especially you are in Ramchandra, dipstick is not all a problem for you.
Urine dipstick.
You want to do, if both are available, still you should still prefer a urine dipstick.
Yes, ma'am.
Okay. And the urine dipstick is specific for albuminuria or for proteinuria?
It's for albuminuria, ma'am.
Proteinuria or albumin? Again?
Albumin. It's for
It's specific for albuminuria. Very good. Urine dipstick is specific for albuminuria. Okay, you have done a urine dipstick. And urine dipstick in a case of nephrotic syndrome, what do you expect to be positive?
It will be 3+ or 4+, ma'am.
It indicates what is the amount of protein it indicates. 3+ indicates what and 4+ indicates what?
3+ is 300 mg per 4+ is 1,000.
Yes. 1,000, more than 1,000 and more. Okay, very good. You have done a urine dipstick. Next, you wanted to do routine. You told me urine dipstick you have done. Next,
We can do urine spot protein creatinine ratio, which will be
deposits you wanted to see.
Cast will have hyaline cast granular.
Hyaline cast, can it occur in normal individuals?
Normal, yes.
Yeah. Yes, or no? Yes, it can occur. Okay, what do you mean by casts?
It's
It is secreted by, or the protein is secreted by which part of the kidney? Which part of the nephron? What is it? Protein?
TAM phosphoproteins will be.
Yes, secreted by? Okay, doesn't matter. DCT or PCT?
PCT.
So you will verify. Huh? Okay. Already you told me you will verify something else also, no? Junks you will verify. You will also verify DCT or PCT. Okay, yes, then proceed. Okay, now you are looking for hyaline cast, but that can also be present in normal pills. Urine albumin, dipstick you have done deposits. Then what else you want to do?
Because this child has had hematuria, we can also look for RBC.
Okay. When do you call it as microscopic hematuria?
If there are more than 5 RBCs per.
What is the latest guidelines? 5 you need or 3 is enough? 3 is enough. 3 to 5 they say. 3 to 5 RBCs per high power field in an uncentrifuged urine. Okay. You are looking, but this child didn't have hematuria. When you looked at the microscopic hematuria, it was normal. Now we'll assume it is normal. Okay. So we leave that. Okay. Next, what you wanted to do? You wanted to do
a? In urine, we'll also urine spot protein creatinine ratio we'll see now.
What is the gold standard for the diagnosis of nephrotic syndrome?
For diagnosis
Spot, I'll be more specific. Spot வேணுமா உங்களுக்கு இல்ல 24 hours urine protein mandatory you feel?
No, ma'am. 24-hour urine protein is not mandatory, ma'am.
The 7 years old child.
Spot PCR is equivalent
Very
to.
good, excellent. நான் எவ்வளவு உன்னை lead பண்ணாலும் நீ spotல நின்னுட்ட. Very good. That 24 hours urine protein is not mandatory. That is a message to be conveyed. It is not mandatory. It is cumbersome and it is not mandatory. Spot done properly is good enough. Now, what is the value you are expecting in this child?
It will be more than 2, ma'am.
It will be more than 2, probably 4 or 6 or whatsoever. Okay, very good. Okay, proceed. Spot you have done. Then what else you want to do?
So next we can do a CBC.
Okay.
Then we'll do serum albumin, ma'am.
Okay. What is the albumin level you want to have? For a child with nephrotic syndrome, yes.
It will be less than 3, ma'am. Less than 3 gram.
Okay, yes. 2.5. New guideline is 3. Yes, very good. Yes, then cholesterol more than?
Cholesterol more than 200.
Any other test you want to do or you want to stop now? You have done a spot, you have done a urea creatinine. Have you done a urea creatinine?
Yes. Urea
You have done a
creatinine.
renal function. Urea creatinine electrolytes you have done.
Yes, ma'am.
What do you expect the values to be?
It will be normal, ma'am.
Normal. Electrolytes?
Electrolytes, normal, ma'am. Can be high.
Mostly normal. Okay. Urea, creatinine, and electrolytes will be normal if it's a case of nephrotic syndrome. Okay, very good. You want to do any other additional investigation for this child?
Since she has had one episode of hematuria and now that she is
Excellent.
7 years old, we can do C3, C4 ANA.
Very good. Otherwise, it is not needed. If it is an uncomplicated, simple nephrotic syndrome, with this you will stop short. One more investigation you will do? No,
We
ஒண்ணே
can
ஒண்ணு பண்ணிருப்பீங்க.
ASO viral markers, ma'am.
என்னம்மா?
ASO viral markers.
No. இது வரைக்கும் கரெக்டா போயிட்டே இருக்கீங்க. One thing only. Always whenever before starting steroids or child is on steroids, always we would like to do a
Hand-to and a chest X-ray, ma'am.
no, X-ray is not needed. Tuberculin test தான் பண்ணுவோம். Man to history of contact இருந்துச்சுன்னா தான் X-rayக்கு போகணும். As per the guideline, there is no need to do even an X-ray. இதோட முடிஞ்சிரும். நீங்க வந்து since this child had hematuria, as you rightly said, you will go ahead and do a complement C3, C4 for this child. Okay, complement levels are normal. What is your interpretation?
It's probably nephrotic only, ma'am.
It is complements are normal. Low hypocomplementemia is thinking in terms of glomerular nephritis. Okay. ASO an anti-nuclear body. Why do you want to do? Why did you want to do an anti-nuclear body for this child?
For the like.
நீங்க தான் சொன்னீங்க female child சொன்னீங்க hematuria race இருக்குது. Anti-nuclear body to rule out what? You wanted to rule out?
Like.
Connective tissue disease. SLE.
SLE lupus.
அதானே நீங்க ரூல் அவுட் பண்ண நினைச்சீங்க இல்லையா?
Yes, ma'am.
Okay. Yes. Okay. Very good. Proceed. But anything else you want to do?
We can rule out
additional evaluation or investigations in this child.
Because
since
urine culture we can do, ma'am, before starting.
Okay, very good. Yes. Transaminases, venuma hepatitis B, HbSAg, transaminases as and when indicated. Okay. Now, is there a role for this child has got frequent relapses? Is there a role for kidney biopsy in this child?
Frequent relapses we can.
For this child, you tell me. For this child, is there a role for kidney biopsy?
If there is persistent microscopic hematuria, we can think about kidney biopsy, ma'am.
But this child, did it have a persistent hematuria?
Only one episode that was painless, so probably biopsy is not indicated in this child.
Okay. Two more indications you tell me for which can be indications for renal biopsy?
Persistent microscopic or gross hematuria.
Very good that you have told me. Yes.
Steroid resistance.
Okay.
Not responding to steroids. When the child is not responding to steroid sparing agents like levamisole.
Calcinure. Okay, yes. Where are the acute kidney injury in spite of hypokalemia, despite correction of hypokalemia? That may be another indication. Okay. Okay, very good. Now for this child, you are not planning a renal biopsy. You have done the investigations. So imagine this child. Now it's a case of frequent relapses nephrotic syndrome. For a first episode of nephrotic syndrome, what is the treatment? You tell me, and then you proceed for frequent relapses. Sangeeta, you want to ask her something?
So, in this child, there is no clear-cut indication of renal biopsy, but we have certain indications like congenital nephrotic syndrome, infantile nephrotic syndrome, and if the child is crossing more than 12 years, that is the recent guidelines. If the child presenting with a nephrotic syndrome for the first time, who is more than 12 years of age, and nephritic onset nephrotic syndrome, systemic features like whenever you are suspecting associated SLE or Henoch-Conn in purpura, child who is having hypovolemia not contributed by furosemide or any diuretics, then you will go for renal biopsy. Yes.
There is no indication. Yes, Rachana, proceed. Now, suppose it's the first episode of nephrotic, so what's the treatment?
First episode. Prednisolone.
Yes.
2 mg per
patient can afford. Can they go ahead with deflazacort?
No, ma'am. Only prednisolone.
Dexamethasone, betamethasone, methylprednisolone. Among these all the four steroids which I have mentioned, which is the best for a child with nephrotic syndrome?
Prednisolone, ma'am.
Prednisolone. Very good. Yes, how much of prednisolone?
So 2 mg per kg per or 60
Okay.
mg per meter square daily for 6 weeks.
Yes.
And then 1.5 mg per kg alternate days or 40 mg per meter square alternate
Single
days.
dose or divided doses?
Anything is fine, ma'am. There's no such thing like we should give single or divided doses.
Divided doses. Okay. Divided means you want to say 8th hourly, BD, anything specifically you will mention? What are you giving?
No, ma'am. It's like
BD you want to give or OD you want to give? You want to give it with antacids? Antipyrrhazole?
Antacids are not indicated for.
Yes, very good. Antacids are not indicated. Any specific instruction when இவ்வளோ steroid எடுக்கும்போது ஏதாவது specific சொல்லுவீங்களா?
Like they can take after food and that.
Good, very good. Okay, they can take after food. No need for antacids or pantoprazole. Very good. Single or divided doses. Prednisolone alone. Okay, yes. Per kg or meter square. எவ்வளோ maximum dose எவ்வளவு?
Maximum is 60 mg per day, ma'am.
Per day. Okay, very good. Okay, then okay, you have started. This is for us. Now this child is having it's a case of frequent relapses according to you. When do you call it as frequent relapses?
Frequent relapses
You have
more.
already told me more than 2 relapses in 6 months or more than 4 relapses in a year, you have told me. For that, what do you want to do?
So we can start with prednisolone at 0.5 to 0.7 mg per kg daily, and then taper to 0.3 to 0.5 mg per kg for 6 to 9 months, ma'am. In case if that child is not responding to that steroids, then we can go over to steroid sparing agents like mycophenolate mofetil, levamisole.
Okay, very good. Now, கொஞ்சம் கொஞ்சமா கேட்போம். இப்போ வந்து இந்த சைல்டுக்கு எனக்கு ஒரே ஒரு டவுட். இந்த சைல்டுக்கு வந்து ஸ்டீராய்ட்ஸ் when you call it as long term steroids, child is having prolonged steroid therapy எப்ப சொல்லுவீங்க? When do you call that terminology?
Steroids for more than 14 days, ma'am.
Okay, how much?
More than 2 mg per kg per day.
For more than 2 weeks, you call it as long. இப்படி இந்த மாதிரி ஸ்டீராய்ட்ஸ் எடுத்துட்டு இருக்கும்போது ஒரு 10 days பாப்பா எடுத்துட்டு இருக்குது. திடீர்னு ஒரு நாய் கடிச்சிருச்சுப்பா.
Okay, ma'am.
Child had a dog bite.
Okay, ma'am.
Child is now long-term steroid, long-term steroids கிடைச்சிட்டு இருக்கும்போது child is immunosuppressed conditionல இருக்குது.
Okay.
Now this child has, so what is the advice for vaccines? What is the regular advice for vaccines when the child is on long-term steroids?
So when the child is on long-term steroids, we are not for more than 14 days, we are not supposed to give live vaccines for 1 month. It should be repeated for 1 month.
Not supposed to give live vaccines for
1 month.
Wait for how many days and then give the vaccines?
Wait for 1 month and then give
the vaccines. Okay, that is the usual recommendation. Now this child had a dog bite.
Okay.
What will you advise? Child இப்பதான் 10th 11th or 12th day of steroid இருக்குது. கிட்டத்தட்ட long term steroids தான். What is your advice for vaccine?
This child can have like based on this child can have rabies immunoglobulin and rabies vaccine the child can take, ma'am, because less than 14 days even live vaccines immediately after stopping steroids it can
vaccines effective இருக்காதே because child is on steroids.
We are giving immunoglobulins, ma'am, and vaccine.
Vaccine she wants to give. Excellent. That is, எவ்வளவு proud பண்ணாலும் you are very confident. That I like about you, Rachana. Very good. Excellent. That is, rabies and tetanus are two life-threatening conditions. So at that point of time, whether immunosuppressed or not immunosuppressed doesn't come into play. Whatever you do to prevent rabies in that child, whether the child is on steroids or not, you have to continue. That is the answer expected. And you clearly told that. Very good. Excellent, Rachana. Okay, proceed. Now, on long-term steroids, first, this child is only on, it is on steroids. You won't give live vaccines for 1 month. If child is taking cyclophosphamide, how long you won't give vaccines?
If the child is on cyclophosphamide, we are not supposed to give for 3 months, ma'am.
Okay, very good. Now, for this child specific therapy, you have told us already. Any supportive therapy you want to tell me?
Supportive therapy, we have, since the child is on long-term steroids for more than for 3 months, if the child is on long-term steroids, then we can give calcium supplements, ma'am.
Calcium and vitamin D supplements you can give. Any other advice? Supportive therapy, ellame with diet, immunization, management of edema. Okay. Edema, how are you going to manage? This child has got anasarca. How are you going to manage edema in this child?
So based
what
on
you call it as complicated nephrotic syndrome?
Complicated if it is associated with complications like spontaneous meningitis, cellulitis, hypovolemia.
Okay, shock, infection, you told me, then thrombosis. These are the three things which you can. Now, this child has anasarca. What is management of edema in this child? What are you going to do for this child?
So edema, first we should rule out hypovolemia because they might have edema, but then there can be features of hypovolemia that has to be seen.
Like, what are the features of hypovolemia going to look at in a child with edema?
The child might present with abdominal pain, lethargy. Regarding the signs, there will be tachycardia, peripheries cold, low
Good.
BP,
Yes.
and blood investigations. There can be hematocrit rise. There can be elevated one and creat. IVC collapsibility will be there, ma'am.
Very good. Excellent. Now, how are you going to manage edema? Now, come back to the same question.
Edema, it is categorized as mild, moderate, and severe. So mild edema is
So
less.
this child is having massive, no? It is having anasarca everywhere. So
So
what are you going to do for this child?
Yeah, we'll start with oral diuretics, ma'am. Furosemide.
For that? Yes, you will start on oral diuretics. Anything else before that?
Lasix and spironolactone will be giving, ma'am.
Okay, just oral diuretics start பண்றீங்க. You want to start furosemide and spironolactone. Can you give potassium sparing diuretic in a case of AGN, acute glomerulonephritis?
No, ma'am, because they'll have hypertension and hyperkalemia will be there.
So we don't give in AGN. Whereas in nephrotic syndrome, can you give spironolactone as an add-on diuretic along with furosemide?
Yes, ma'am, we can give, ma'am.
You can very well give because they are more prone to have hypokalemia, and if you give a potassium sparing diuretic, no harm. So you can add Lasix, furosemide and spironolactone as a diuretic. Okay, then still after giving both the diuretics also, if the edema still persists,
we can switch over to IV diuretics. We can try IV furosemide, or we can switch over to metalazone hydrochlorothiazide.
Yes, still not coming down. Still edema is not coming down. Steroids, do they bring down the edema?
Yes, ma'am, but then the action, it will take 7 to 10 days for the steroids.
Very good, very good. எது கேட்டாலும் கரெக்டா சொல்ற சங்கீதா, excellently you have coached us, Sangeeta. Yes, next சொல்லுங்க. Okay, yes, அடுத்து steroids will take a longer period, so you cannot wait for such a long period. So நீங்க metalazone வரைக்கும் போயிருக்கீங்க. அப்ப if edema is not coming down, then
you can give albumin transfusion, ma'am.
How much?
It is 0.5 to 1 gram per kg. 20% albumin over 3 to 4 hours it will be given. But then we have to add Lasix at the end of infusion, ma'am.
Yes. Okay. Good. Very good. Now you have this child is on long-term prednisolone for quite some time. What are the things which you want to monitor in this child?
So we should see height. We should see if there is stunting.
Height and weight. Height, how frequently?
Height we should see every 3 to 6 months, ma'am.
Okay. Then any other evaluation you want to do?
Evaluation, we should look for hyperglycemia, BP. Eyes, we have to look for any cataract, glaucoma. Then
evaluation, how frequent?
6 months, ma'am.
Okay. Yes.
We can look for psychosis, myopathy, osteonecrosis. Like in the anthropometry part, we should look for the growth velocity if it is less than 3 standard deviations. That is worrying.
Okay, growth velocity. Anthropometry every 3 months you have told me. Okay, if this child it's a case of frequent relapses, you have started this child on levamisole. What did you give? Levamisole.
Frequent relapses, first initially we'll start with prednisolone at 0.5 to 0.7 mg per kg. And then we can switch over to 0.3 to 0.5 mg per kg for 6 to 12 months. In case if it is not responding, then steroid sparing agents like mycophenolate mofetil, levamisole, then cyclophosphamide and adukum.
Wait. Levamisole and MMF. These are the two drugs which you have started. What are the things which you will monitor well on levamisole and MMF?
So if the child is on levamisole is prone to cause leukopenia, child can have seizures, bone marrow suppression. Mycophenolate mofetil, it is more hepatotoxic, ma'am.
So you like to monitor the transaminases?
Transaminases, yes, ma'am.
How frequently?
Every 6 months, ma'am. 3 to 6 months, ma'am.
Okay. Okay. Sangeeta, anything?
So as this child is having frequently relapsing nephrotic syndrome, Rachna, do you want to continue the child on low-dose steroids, right?
Yes, ma'am.
So you will monitor for the steroid side effects. As you have already discussed, you will look for the steroid side effects at any point of time. If the child is in need of more than 0.7 milligram per kg as maintenance dose of steroid, or any steroid side effect like hyperglycemia, hypertension, obesity, then you will switch the child to some other medication. What are the alternative medications you have? More than MMF, what drug do we want to start initially? Levamisole.
Yes.
Okay. Levamisole, earlier it was used as an anti-worm medication, but it is again immunomodulated drug, which is used for frequently relapsing nephrotic syndrome and steroid-dependent nephrotic syndrome. It is a harmless drug, but still you have to monitor liver function test. It can rarely cause liver enzyme elevation. So every 3 to 4 months, you have to look for leukopenia and enzyme elevation. I would recommend you to start the child on levamisole. Along with that, low dose of steroids will be given for 6 months to 9 months. You will be tapering the doses of steroids at 6 to 9 months, and levamisole 2 to 2.5 milligram per kg per day, alternate days, will be continued for 1.5 to 2 years.
Okay.
Once the child is maintaining remission, then you can stop it.
Okay.
Yeah. If the child is not responding to levamisole, go for cyclophosphamide, then mycophenolate mofetil.
Okay.
Okay. ரொம்ப simple. See, frequent relapses nephrotic syndrome, refer to a pediatric nephrologist like a Sangeeta. That's what we as pediatricians, நம்ம வந்து அதோட நிப்பாட்டிக்கணும். 2 எபிசோட் வரைக்கும் நம்ம பார்க்கணும். After that, hand it over them. அவங்களாலேயும் அதை ட்ரீட் பண்ண ரொம்ப கஷ்டம் தான். அதனால let it go to them. Okay. ஒரே உனக்கு ஒரு question. If the child is on steroids, child develops high fever, or running nose, child comes to your clinic, what will you do immediately? Stop steroids, you want to continue steroids, you want to increase the dose of steroids. Among these three, what do you want to do?
You should give stress dose of steroids, ma'am.
Okay, very good. You don't want to stop steroids. That's very good, excellent. In a fever, நிறைய பேர் usually practitioners நிறைய பேர் stop பண்ணிடுவாங்க. Never do that. You want to give stress dose of steroids. Okay, depending upon the type of severity of the infection. What stress dose of steroid? What do you mean by it?
So it can be either hydrocortisone or prednisolone, ma'am. Hydrocort at 30 to 50 mg, 30 to 50 mg per kg, or prednisolone at 0.3 to 0.5 mg per kg for 5 to 7 days we'll give, and then we can switch over to like the daily dose.
Whatever dose the child is having, steroids.
Hydrocortisone dose alone is 4 to 10 mg to start with. First dose will be high, but followed by 2 to 4 mg per kg is enough. Okay, and when the child is taking orally, you can, it is a range again, 0.3 to 1 milligram per kg, but only in case of varicella infection, you have to bring down the steroid to the lowest dose possible.
Okay, ma'am.
Okay, yeah.
Now, what are the common infections these children are prone for?
They are.
That's why we are very worried about pneumococcal vaccine. Anything? No, 10 minutes. I think we'll wrap up, sir. Anything? Most of the questions we have completed, sir. Infections, complications of nephrotic syndrome, and when do you call it as a relapse? These are the last 2 questions for me.
So complications of
this relapse you have treated adequately, Rachana. Then when do you call the child has gone in for remission?
Remission is 3 consecutive samples show nil or trace of urine albumin. It is remission, ma'am.
Okay, that is remission. 2 common infections which you see in children with nephrotic syndrome.
They'll present with peritonitis, ma'am. Spontaneous bacterial peritonitis.
We could keep on telling, but we rarely see where.
Cellulitis.
Okay, peritonitis I accept. Yes, spontaneous bacterial peritonitis. Yes. Cellulitis and pneumonia. I have seen more frequently. Okay, they can go in for sepsis, septic shock also. Rarely varicella infection may be a problem in these children. Have you seen a child with thrombosis, renal vein thrombosis with nephrotic syndrome?
Renal vein
அதே மாதிரி நம்ம நிறைய சொல்லிட்டே இருக்கோம். நான் ரொம்ப ரேரா தான் பார்ப்போம். ரீனோமெகலியோட அவங்க பிரசன்ட் பண்ணுவாங்கன்னு சொல்லலாம். More commonly we see cortical venous thrombosis, especially in children who have diarrhea, dehydration, they will go for cortical venous thrombosis. Excellent. I have completed my questions. Rachana, you were the best. You did extremely well. Over to SBS sir and Sangeeta.
Excellent, excellent. That was
Yeah, I learned a lot
All
from your
questions.
questions. I
Very
learned a lot from your questions, madam.
fantastic.
Thank you, sir. Sir, thank you, sir.
Well done. Few comments. Having listened to, definitely I can't keep quiet, but comment. Comment one, there was a discussion on the appropriate antibiotic for impetigo. It's preferable to use a first or second generation cephalosporin instead of amoxiclav. The reason is amoxiclav has got much broader spectrum, and we rarely use the first generation cephalosporins like cephalexin. Cefadroxil is very cheap, dead cheap. Representatives won't even promote the drug to you. So you can give cefadroxil 40 or 40 milligram per kg or cephalexin 50 mg per kg. It's better to avoid amoxiclav for skin and soft tissue infections because you don't want to cover any E. coli. You want to cover only beta streptococcus and MSSA. And amoxicillin will be ineffective in impetigo because majority of the impetigos are caused by staphylococcus. Amoxicillin will not work even against methicillin sensitive Staph aureus. Comment number 2.
Rightly said, sir. She was in between amoxicillin or amoxiclav. So I was worried that she might tell amoxicillin, amoxiclav was only serintec. But as sir rightly said, cefalexin or cefadroxil are the initial drugs of choices always.
Cloxacillin if available. That's one. Second is in the negative history, she mentioned cough and she said the cough is against group A beta hemolytic streptococcal pharyngitis. If cough had been there, it is more viral. That's my comment number 2. Third is very important to recognize that the latency in post-streptococcal glomerulonephritis, the latent period in post-streptococcal glomerulonephritis is different in impetigo and in pharyngitis. In pharyngitis, it is 2 to 3 weeks, whereas in impetigo, it's 1 week. So, good history of impetigo can easily be obtained if there is nephritis. That's my comment number 3. Comment number 4 is that, of course, Dr. Suresh has also put in the chat box, the vaccines that you mentioned there, the term optional vaccines is not the correct term. Dr. Suresh has already put in the chat box. They are all IAP recommended vaccines. So the term optional vaccines has been removed by the ACVAP long time back. Please do not use the term at all. And in the history, you should have given details of the treatment. Even if it's irregular treatment, doctor, you did not, of course, don't think I'm finding fault. You are getting distinction anyway. But you would have been D plus if you had mentioned the details of treatment. It's very important to find out what are the drugs that were given, what is the duration, and very important, you never said whether she responded to steroids, when she responded to steroids. Because in the history, 4 episodes, I was not very sure whether it is a steroid responsive nephrotic syndrome which is relapsing or it's persistent. That should have been obtained. Next comment is in the general appearance of the patient should have been described, where she is ill, obese, and I'm sure she is very thin because the BMI is only 11.6. And in the abdomen findings, specifically, you should have mentioned that you could not palpate the kidneys. It's very important because however rare it might be, in renal vein thrombosis, you may get a palpable, sometimes tender kidney. I have seen only one case in 40 years. So that I remember the nephrologist picking up the palpable kidney and confirming the renal vein thrombosis. And the other comment I wanted to make, doing blood counts in nephrotic syndrome is not only for infection. Like dengue, you must look at the PCV in nephrotic syndrome. It is crucial to look at the PCV because if you are going to give a diuretic to somebody whose PCV is 40, you're going to end up in disaster with thrombosis. The child might be already dehydrated. Please look at the PCV carefully. Okay, sir. And one final comment, I would want Dr. Sangeeta's comments. I remember reading that the ISKDC had always preferred For initial treatment of nephrotic syndrome, divided doses and further relapses, single dose. Does that hold good even now? Or the nephrologists have now started giving only single dose even for the initial treatment? These are my comments. Excellent presentation, distinction, well done. Of course, I mean, more compliments to Dr. Lakshmi are needed. Fantastic. Well done. Thank you very much.
Thank you, sir.
Thank you, sir. Sir, regarding this ISKDC regime, the recent guideline on SSNS or by ISPN, Indian Society of Pediatric Nephrology, they advise us to give divided doses or single dose as steroid. And in practice, as a practitioner, I would like to give a single dose in the morning. Many children, the compliance is very poor and they miss the dose when we divide it and give it. And it is easy to give it in the morning, sir. In practice, so still we advise daily dose only. Daily dose of steroids in the morning.
Okay, one other comment. I think in this child, I wouldn't do ANA and waste money. Very simple, because this child doesn't have anything else happening outside the kidney.
Yes.
This can't be lupus, and ANA can be positive in 10% of normal children. ANA positivity should not lead you to a misdiagnosis of SLE based on that only.
Okay, sir.
I don't think I would waste my money by doing you must remember 10% of Indian population are known to be ANA positive.
Okay,
So
sir.
I don't think you should consider doing ANA. If at all you have other features of SLE, I think you should go straight away for, if you have clues like decrease in C3 and C4, perhaps aggressive investigations with with your anti-DS DNA would be more appropriate rather than doing ANA. Even ASO for this child who has had 4 relapses is a waste of money.
Okay,
And
sir.
a very important point you must remember is that ASO may not go up in post impetigo glomerulonephritis as much as it goes up in pharyngitis. It is anti-DNAs which will go up following impetigo, not ASO. Whereas following pharyngitis, both can go up.
Okay, sir.
Okay. Yes. Thank you very much, sir. Again, I would like to congratulate Rachana for that excellent presentation. I was just bombarding you with questions. So, exam answer. It was really wonderful, Rachana. What all we have not dealt, usual class of nephrotic syndrome, we always tell primary nephrotic syndrome, minimal change nephrotic syndrome, mesangial focal segmental glomerulosclerosis, mesangial perfusion, what percentage, 85%, 5%, 5%, all that pathological part that we usually tell, and secondary causes of nephrotic syndrome. For example, drugs producing, all that we usually discuss those pathology, pathogenesis, like the loss of podocytes, all this we usually discuss in a theory class of nephrotic syndrome. When you write an essay, all that we just conveniently, for want of time, we skipped. We went more into the practical aspects of nephrotic syndrome. How do you arrive at a diagnosis? How do you treat a child with a nephrotic syndrome? I think we are on time, sir.
One
9
minute,
o'clock.
Dr.
Yes,
Lakshmi, there are 2
Yes, sir.
questions from the chat box. One is, of course,
I didn't.
Manto
Okay.
test before starting first episode on nephrotic
Yes,
syndrome treatment.
mandatory.
I think it is mandatory, but unfortunately now Manto is going out.
So
The
CTB.
Serum Institute CTB test is going to be introduced by the ICMR for routine use. If somebody can afford, it's better to go in for quantiferon TB Gold instead of doing Manto with high
Manto, yes, sir. Manto is not available. The
Available,
Manto
yeah.
fluid is not available, though it is extremely cheap, and we are complacent or comfortable with it. It is not available. So
Yeah.
even if it is costly, we are going to go for quantiferon, or for CTB is going to be the best test. But X-ray test in a case of nephrotic syndrome, as per guidelines, is not mandatory. And for further reading, or the only reading for you for nephrotic syndrome is, you can go through our standard treatment guidelines by IAP. They have given very good guidelines for nephrotic syndrome, for hematuria, and for AKA. So before coming to these classes, you can read. And now recent article in IJPP on nephrotic syndrome. These two articles are really will be very useful for any postgraduate for further reading and completing your class. Thank you very much, sir. Thank you, SBS, sir.
One more question is there. One more question. Somebody has asked,
Yes.
intradermal ARV be used? The answer is no. Intradermal ARV is not to be used in day-to-day practice. It is reserved for public health settings. Okay, technically it is difficult. Intradermal is not recommended. If you want to give ARV to somebody who's on steroid, better give intramuscular ARV rather than intradermal. Intradermal is not recommended by practice.
Yes. 100% I agree with you, sir. Because rabies is one life. It is a disease which can kill a patient. So there we cannot take any risk. So ID is anytime not preferable when compared to regular ARV. Yes, sir. Anything more? Sangeeta, you want to say something?
Sangeeta, madam, your final comment.
Yes. Madam and sir have extensively discussed about nephrotic syndrome and acute nephritic syndrome. As a pediatric nephrologist, I'd like to ask Rachna, when will you refer a child with a nephrotic syndrome to a pediatric nephrologist?
Very important question.
Especially for Sangeeta. Yes, very good. I think she already mentioned 3 conditions. Maybe you can continue, repeat it, Rachana.
So when the child is having atypical features, ma'am, child who atypical features, child who is not responding to steroids, that is frequent relapses with steroids or infrequent relapses, but then a child has developed features of steroid toxicity, will refer to nephrologist, ma'am, for the use of the higher.
When you have a child with a steroid sensitive but going for frequently relapsing, and before starting calcineurin inhibitors, we do renal biopsy. So you will refer the child. And straight away, child with a steroid resistant nephrotic syndrome, syndromic features with the nephrotic syndrome, systemic onset diseases like HSP or lupus nephritis with the nephrotic syndrome. And when you're suspecting familial nephrotic syndrome and genetic diseases, then you have to refer the child to the specialist. It is a wonderful presentation, Dr. Rachna.
Thank you, ma'am.
And one last point, for not only for congenital nephrotic syndrome, nowadays, even for children less than 1 year, we send them for genetic testing, sir. Or 6 months to 7 months, genetic testing we are sending because it is available under CMCHs, and our pediatric nephrologist, nephrologist Dr. Balaraman usually insists that we do send a genetic test. Sir, I will just conclude with that. Sir, thank you very much, IAP CCB, especially Dr. Prasanna, for having given this opportunity. It is always a great pleasure having any class with SBS. That's what I always like to do. And thank you, Sangeeta, for the wonderful presentation. Rachna, again, I would like to congratulate you. It was the very good presentation by you. Thank you, everybody.
Good night, all of you.
Good night, all of you.
Thank you.
Srinivasan, sir, thank you very much for the patient listening. Sir, thank you very much, sir.
Thank you a lot, madam.
Thank you, sir. Thank you, sir. Thank you, sir.
Over to Prasanna.
Prasanna, you can conclude.
Yeah. I thank all the participants for staying with us, 100 participants throughout the session. I thank Dr. Lakshmi Velmurugan madam and Dr. Sangeeta. Actually, they were batting like Rohit Sharma and Virat Kohli. And then SBS sir finally came and gave 4 sixes like Sky, Surya Kumar Yadav. So it was a wonderful session. I don't know. All the PGs who joined, they were they should have been blessed with such session. Across Tamil Nadu, PGs have joined, and many cannot attend sessions by stalwarts like Madam and Sir. But this platform has made those people to share the knowledge to the Kadakodi, Tamil Nadu Kadakodi varaikum நம்ம reach ஆயிருக்கோம். So it's all under the vision of Dr. Somasundaram sir. I thank all the participants and I thank all the delegates. Thank you so much.
Thank you. YouTube link மட்டும் அனுப்பிடுங்க பிரசன்னா.
Sure,
இருக்கா? Okay, thank you. Thank you, sir.
YouTube also 84 people were there in the YouTube.
Oh,
because 100 people was full, rest all joined in YouTube.
YouTube. Thank you, sir.
All of you.
Thank you, madam, for your.
Thank you so much. Okay, thank you so much.
Thank you, madam. Thank you. We will all meet again with yet another session with the.
Another session. Thank you.
Thank you, madam. Thank you. Thank you, SPS sir.
Thank you.
Thank you, sir.
Thank you very much for being here till the last. Thank you, Professor Srinivasan sir also. Thank you, Prasanna. You have given wings to the yet another second session. Okay.